Hi there. Today we are going to continue talking about our exemplar of perfusion with our topic of disseminated intravascular coagulation, or DIC. So, a little pathology of DIC. We have to remember that DIC is not a primary disease or complication, but it is a complication of a trigger that has caused it. So in DIC, we have a hematological disorder that is associated with enhanced coagulation that results from the release of a procoagulant factor as part of that inflammatory response that is associated with sepsis, trauma, some obstetrical complications, and even cancer or blood transfusions. DIC is typically described in two separate phases, a clotting or thrombotic phase and then a bleeding phase. But in some cases, these two may be actually occurring simultaneously. So in that initial thrombotic stage, this may last for hours up to several days. But once it is triggered by that endothelial damage, we have an activation of the clotting cascades, where there's large amounts of thrombin that are being produced in response to this reaction. This will result in excessive production of fibrin clots and the consumption of clotting factors. So we have this excessive coagulation and clots being formed in the microvascular system, and this is building up everywhere. So you think about your patient having signs and symptoms of cyanosis and ischemia. They may have little microclots developing in their fingertips and in their toes and getting ischemia in these areas. This is also where these clots can be developing and getting stuck in any kind of organ. So we can present with organ ischemia and failure as well. Patients are at high risk for thrombophlebitis, pulmonary embolisms, and even strokes. The second stage starts, or the bleeding stage starts, with that initiation of fibrinolysis. This is the process that occurs in an attempt to break down and remove those clots. The breakdown of the clots results in increased circulating of fibrin degenerating products, which these are powerful anticoagulants. They will impair the activity of thrombin, resulting in decreased ability to form that fibrin clot. The combination of the lack of available clotting factors and that anticoagulation properties results in excessive bleeding due to that inability to form the clot. So as we see it kind of broken down in here, we have that trigger from the endothelial damage. We have an activating of the clotting cascades. Excessive thrombin overwhelms that anticoagulation system. We have the microvascular clots that build up. And then our fibrin is activated to try to break down those clots. And as that's doing that, we have no more clots, no more platelets, no more clots being able to build up. And so then we lose that clotting ability and we start to bleed. Now, some of the things that can cause DIC, remember, it does not start by itself, but it is triggered by a complication. It can be a severe illness such as sepsis or septic shock, gram-negative or gram-positive infections. We see it in obstetrical complications and tissue damage such as preeclampsia, placental abruption, or fetal demise. It can be seen in major trauma, cancer, and even blood transfusion reaction. This can be anything that can cause these clots to be forming and start occluding your tissues and your organs. DIC is considered a medical emergency, and it is warranted to find the cause and have immediate treatment because you have a high risk of mortality with it. Some of our clinical manifestations that we see is going to be related to that widespread damage to the vascular system, causing that capillary permeability, vasodilation, and macrovascular clotting, resulting in a decreased blood flow everywhere. The clots can go to, like I said, anywhere peripherally, fingertips, toes. It can go to any organ. So when we're looking at this, we're going to see bleeding and thrombosis. So not only might we see the thrombosis and ischemia, but we might see bleeding, so ecchymosis, pallor, petechiae all over the body. We might see peripheral cyanosis with that decreased perfusion from the thrombosis. In our cardiovascular system, we're going to notice an increased heart rate secondary to that bleeding. We're going to notice a decreased blood pressure. Our respiratory system, we are going to have decreased perfusion. So with decreased perfusion, we are going to have hypoxia, shortness of breath. We might notice a delayed capillary refill. And with those microvascular clotting and bleeding, we might notice a bloody sputum. With our central nervous system, due to that decreased perfusion, we're going to have hypoxia. And what are we going to have? Confusion, restlessness, agitation. With our urinary system, we're going to notice hematuria. In our gastrointestinal system, we can have GI bleeding. In our integumentary system, we're going to notice any type of opening in the skin, any incision, any needle poke. We're going to have severe bleeding that is unstoppable. We might notice mottling of the skin and temperature changes. We're going to have cooler skin due to that decreased perfusion. And with the clotting, we could possibly even notice gangrene in severe cases. With the medical management of DIC, diagnosis is based on the clinical picture in combination with some of our laboratory results. We see a decreased level of fibrinogen, an increased fibrin degeneration products, increased D-dimer levels, which this is an indicator of clot breaking down. We have decreased platelets, prolonged prothrombin, and activated partial thromboplastin times, and decreased antithrombin 3 levels. Some of the other lab work that we're going to notice is our CBC. We're going to notice a decrease in our red blood counts, our platelets, and H&H. With our coagulation studies, again, we're going to see an increase in that PT, PTT, and INR. We're going to see a also possible decrease in our kidney renal function test. And we might see Hemoccult stools when we're checking for GI bleeding. And with our ABGs, we're going to routinely monitor the ABGs because we want to assess for that gas exchange. We want to check for clotting to the lungs and also make sure that we're maintaining adequate tissue perfusion. So when we're looking at DIC, it is important to treat the underlying cause. We need to find out what the cause is that's causing the patient to go into DIC, and without treating that cause, we're not going to be able to fix the complications. But other management of DIC involves vigorous treatment of trying to stop that excessive clotting and bleeding, which your patient might have hypotension, hypoxia, respiratory distress, and possibly metabolic acidosis associated with that poor tissue perfusion. Additional supportive treatment consists of volume replacement. We're going to balance crystalloids such as lactated ringers, blood replacement, and possibly replacement of that clotting factors with FFP and platelets. The use of anticoagulation is not routinely recommended, but you might see early use of heparin if that clotting factor, that first initial thrombin phase, is caught early enough. With supportive care, we also want to prevent any further bleeding or thrombosis, so we want to avoid IM injections or repeated sticks or invasive procedures. For pain control, we do not want to use heat as that will cause vasodilation and increase bleeding. We can use cool temperatures to help with some of the pain, but we definitely want to be cautious with their bleeding and help try to enhance that perfusion that they have. Some of the complications that we're going to see with DIC we've talked about. The thrombosis is going to lead to decreased perfusion all throughout the body, and that can eventually lead to necrosis of tissue and organ death. We're going to see decreased cardiac output, hypoxia, possibly the patient going into metabolic acidosis, and eventually, if not corrected, can see multi-system organ failure. Some of the nursing diagnoses with DIC, we're going to see ineffective tissue perfusion, impaired gas exchange, pain, and fear. Patients, this can happen very quickly and suddenly with patients, and again, it is considered a medical emergency with this going on. Some of the interventions is we want to, when we have a patient that falls into any of these categories with pregnancy complications, sepsis, blood transfusion, severe trauma, we want to assess for that bleeding and bruising ahead of time. We want to monitor our vital signs, our level of consciousness, take strict intake and output, and note for those bleeding precautions, because the earlier we can catch DIC, the better prognosis that our patients have. So we want to make sure we're looking at those causes. With our planning process, we want to make sure our patients are getting adequate tissue perfusion, that we're maintaining adequate gas exchange, so we're going to be checking those ABGs, making sure they're perfusing. Adequate pain control, because those microvascular clotting, necrosis is very painful to these patients. And then again, early recognition of this illness progression to stop the clotting cascade before it starts. With implementation of some of our processes, so a patient in DIC is going to be managed by a critical care team. We're going to focus on assessing for that bleeding, prevent further injury, and administer prescribed therapies such as your IV fluids, your blood products, your FFPs, or your platelets. We're going to carefully assess all body systems. Remember, those microvascular clots can get anywhere, so we want to make sure we are monitoring all parts of the body, checking dependent areas for cyanosis or necrosis, looking at your stool for blood, assess your capillary refill, assess for your vital signs, your level of consciousness. You're measuring your intake and output, monitoring your urine for blood, institute any type of bleeding control precautions, so no sticking that's unnecessary, no invasive procedures that are unnecessary. Maintaining good skin integrity, turning our patients frequently. We're going to ensure adequate nutritional intake to help promote healing. Looking at a good health